Yes, so Amani asked what our tools, what our preference, our tools of preference, and now we are going to focus on the mechanism of action of these different tools that now we have in our CAD labs. Obviously, not in all CAD labs we have the chance of having all these tools, but anyway, they are now available, so they deserve a little bit of discussion in this next presentation. So before moving on into a deep dive of different tools, let me just spend a minute of clarifying our terminology, because we sometimes use in a similar fashion the words plaque debulking, plaque modification, and lesion preparation, but they are not the same. And let me just spend a couple of seconds telling you why they are not the same. So plaque debulking, it means that you are debulking, you are taking away something. It means that you are taking away calcium, obviously. And so it refers, the term plaque debulking refers to atherectomy devices. We now have rota, we now have orbital, we now have laser. And the three of them remove a little bit or a lot of calcium. The term plaque modification refers to all the therapies that are not ablation therapy. So all the therapies that are balloon based. So we are talking about non-compliant balloon, super high pressure balloon, cutting or scoring balloons, IVL and lytics. They are the one that we have right now. Then after plaque debulking and plaque modification, there comes lesion preparation. As our colleague pointed out, the role of using non-compliant balloon in this setting is fundamental, because after you took out some calcium, after you created some cracking, then you have to prepare the lesion for implanting your stent. Because what we know is that when the calcium is thick, when the calcium is big, when the calcium is severe, what we do with standard balloons or even with non-compliant balloons is just to push our balloon on a wall, and so we increase the pressure while we are not increasing the inflation of the balloon itself, so we are not preparing the lesion. On the other hand, when we use our debulking system or preparation system, so balloon-based or ablation-based technologies, we remove calcium and create crackings, and then we modify vessel compliance in order to be ready to do lesion preparation. And what is happening after this, after creating crackings and taking away some calcium, is that inflating our balloon, our non-compliant balloon, we are in fact inflating the balloon, not only pushing pressure against the calcium. And so when the vessel compliance is modified, this is the portion of the PCI that we are calling lesion preparation. We are inflating the balloon, the vessel is ready to be treated with stent or DCB, but mainly stent, especially for calcific lesion. Once again, imaging is fundamental to understand when we have to use them and also when they were effective. Let me show a thing. So Jacob already showed us that calcium length, calcium angle, and calcium thickness are really important. But the other point is calcium morphology. Morphology will guide your tool selection, because at different morphologies correspond different treatments. And these are the three main morphologies that we can treat: concentric calcium, eccentric calcium, and nodular calcification. And we call them in Milan the good, the bad, and the ugly, because they require different therapies, and they also are different in terms of risk, acute risk, and chronic risk of stent failure. So it means that the good one, that is the concentric calcification, is the calcium that you can remove, that you can debulk, that you can take away with rota. And what we are expecting when we do this type of debulking is that we start with thick calcium in a small vessel, we do our rota, and then the calcium changed. After rota, we can see the reverberation starting, and so now, after doing our thickening technology, so our debulking technology, we are ready to start plaque modification and lesion preparation. So we remove the calcium, and then we are ready to do the lesion preparation with our non-compliant balloon. Usually non-compliant balloon, sometimes you will need IVL, sometimes you will need cutting, but usually after rota, non-compliant balloons are enough. And I show you how, because when you do a good calcium debulking, afterwards you inflate your non-compliant balloon, and you see these, that are the one that already Jacopo and everyone knows them, are called crackings. So these discontinuation in calcium that are related to a good lesion preparation, and it means that you are going to safely implant your stent and to have a good angiographic and imaging result. Because what we did is to increase plaque elasticity, to increase vessel compliance, and to prepare the vessel to be ready for our stenting. And this was the good one, because when the calcium is concentric, you can do almost whatever you want. You can do rota, you can do orbita, you can do IVL, you can do cutting or scoring, whatever you want. The bad one is eccentric. The eccentric calcification is bad for two main reasons. The first one is that you can think that you did a good job because you inflate your balloon, and in some projection you can take the risk of not seeing that the vessel is still non-prepared. So you inflate your balloon, and you can take the risk of missing that the vessel is still eccentrically calcified, and then you take the risk of implant a stent that may be underexpanded. But, and this is worse, if you inflate your balloon and push up with atmospheres in concentric calcium, you do nothing because the calcium is there in every direction. In eccentric calcium, you can take the risk of pushing the balloon on the side of the vessel that is less hard to be dilated, so in the healthy part or in the non-calcific part of the vessel, and sometimes you can create this tear in intimal and medial plane that, if you are lucky enough, are only dissection like this. If you are not, they can become perforation, actual perforation. So this was one of the rare cases when we did imaging for detecting a perforation, and you can see here on the bottom side of the IVUS that we caused this big blood extravasation because the tear that we created with non-compliant balloon went down to the adventitia, and we perforated the eccentric vessel. So how to treat eccentric vessel? We still don't know. Still, we do not have a clear answer to this question, but just don't forget that if you're doing a debulking strategy, it may be hampered, it may be reduced in efficacy from wire bias, because the wires sometimes push your rota on the side where the calcium is, sometimes it does not. So a good choice may be IVL, because IVL obviously works better when the calcium is concentric, but it works well also with eccentric calcification when the calcium is on one side, and then again after doing IVL you did a good plaque modification and you are ready for your lesion preparation with non-compliant balloon. So it is possible that for eccentric calcification, IVL or lytics may be good choices in order to prepare the lesion. The last one is the ugly. I think that we can spend hours discussing about nodules because no one have a clear answer yet to nodules. But for sure, what we do not have to forget is that nodules may be eruptive, may be non-eruptive. The difference is not so easy to be seen at angio, is almost impossible. Even at imaging, sometimes it's not easy to discriminate eruptive nodules and non-eruptive nodules. But the only thing to remember is that for sure, balloon is not enough for nodules because you are not taking away any calcium. Probably rotational and orbital atherectomy, if you are lucky enough that your guide wire push the burr or the crown on the nodule, may be sufficient. probably the solution for nodules is a combination therapy of ablative techniques and IVL, so the so-called shave and shock. That is the brand new choice for this type of therapy. So in fact, the presentation was over. Hopefully it was clear that we obviously have to select our choice, our tools for debulking based on imaging and also our availability and experience. That is pretty important. Thank you.